So this is the basic principle of ultrasound. This is the transducer. The patient end of the transducer is lined by an array of piezoelectric crystals. And when these crystals are stimulated by an electrical impulse, they set off a sound wave which is propagated in the direction of the organ. Upon reaching the organ, a portion of these sound waves are returned, and this returning beam is also called an echo. And it is captured by these crystals and transmitted to the screen to be displayed as an image. So depending on the sound waves at the interface, the structure that you wish to image could be totally dark in relation to the surrounding structure, in which case this is called anechoic. If it is the same intensity as the surrounding structure, it is called isoechoic. If the structure you want to see is slightly darker compared to the surrounding tissue, it's called hypoechoic. And if it is brighter when you compare it to the surrounding tissue, it is called hyperechoic. As I said, a transducer or a probe is a very important part of the ultrasound machine. It both transmits and receives the ultrasound beam. It makes contact with the patient's skin, and since this is a very costly piece of equipment, you need to render it sterile before you do your blocks. It takes thin slices of the object being imaged, and each slice is about 1 millimeter in thickness. You can rotate or change the transducer to get your views. And basically, you have two types of transducers. A high-frequency transducer gives you an excellent image, but the depth of penetration of these waves is limited. Therefore, a high-frequency transducer is useful only for superficial structures, which is what we need for most blocks that we do. A low-frequency transducer does not give you a very good image, but the depth of penetration of ultrasonic waves is very good. So this transducer is good for deep blocks and also for neuraxial imaging. So these are various types of transducers. This is a curved transducer. This is a linear transducer. This is a phased sector array transducer, which is useful for transthoracic echoes and lung ultrasound, where there's a very narrow space for you to put your ultrasonic transducer. And this is a hockey stick probe, which is very useful for pediatric applications. An artery is black, but then you can recognize an artery because it pulsates. A vein is also black, but you can recognize a vein because you can compress the vein by your ultrasound probe. And the muscle has a bright fascia which encloses a darkish muscle mass. So if you see here, that is the pulsatile subclavian artery. That's the subclavian vein right next door. And this is the muscle mass. This is the pectoralis major, this is the pectoralis minor, and this is the infraclavicular plexus, which is around this artery over here. Ultrasound appearances of nerves, you can do it in short axis or long axis. This is the probe placed in the forearm, and that is the median nerve. You can see it as a nodular structure, which is not homogeneous, but it is heterogeneous, and it's a speckled structure because it contains bundles or fascicles. And in long axis, this looks like this, a fascicular appearance. Echogenicity of nerves, Bala just spoke to you about. Closer to the neuraxis, there is a preponderance of neural tissue. Therefore, above the clavicle, the nerves, this is the subclavian perivascular plexus there, they appear as dark rings. But as you go farther and farther away from the neuraxis, more and more connective tissue is added, and it is this connective tissue that imparts brightness to your nerve on ultrasound. And peripheral nerves look very bright. There is something called adjusting your gain with ultrasound, which is something like your contrast on your television sets. What gain does is it amplifies the returning sound beam, is also called the echo. And as you can see, this gain is just right. Here the gain is too dark, and here the gain is too bright. So you need to adjust your gain on the machine when you perform your block. So also you need to adjust the depth. This nerve here should be in the center of the field. If the depth is too shallow, the structures will appear very magnified, and you could actually lose your structure. And if the depth is too much, a lot of structures beneath this structure you want to see will come into view, and that can actually confuse your search for the nerve. Color Doppler, again, is an important technology that allows you to quantify blood flow. If the transducer is applied like that, and the shift of the column of blood cells within the vessel is away from the transducer, the perceived shift of frequency is said to be lower, and this will appear as blue. Whereas if the column of blood vessels is towards the transducer, the perceived shift of frequency is said to be higher, and it will appear as red. So with Doppler, veins are not always blue, arteries are not always red. If the direction of blood flow is towards the transducer, it will be red. If the direction of blood flow is away from the transducer, it will be blue. You can identify an artery because it pulsates. You can identify a vein because you can compress it with your transducer probe. As I said, you have to render the probe sterile before you perform any block. You can do it in various ways. Transducer orientation is very important. There is an index mark, or orientation marker. We will show it to you when we do the workshop on the left top hand corner of the screen. And this always represents the right side of the patient when the probe is in short axis, and the head end of the patient when the probe is in long axis. So how you can do it is, for example, if this is the probe, you apply some gel on that, and you just wiggle it on one end. If you see the movement towards the orientation marker, that indicates the right side. And when you place it in short axis, that has to be towards the patient's right, and in long axis, it has to be towards the patient's head end. Coming to needle approaches, there are basically two ways you can put the needle under the transducer. One is along the ultrasound beam, and you will be able to see the entire shaft of the needle. And the other is across the ultrasound beam, and only that part of the needle that transects the ultrasound beam will be seen as a bright dot on your screen. So this is called the in-plane approach, and this is called the out-of-plane approach. So as you can see here, this is short axis. Again, this is short axis, and these two are long axis. This is short axis out of plane, short axis in plane, long axis in plane, long axis out of plane. This is self-explanatory. Yes? Yeah. So when you want to buy an ultrasound machine, we'll talk about this in What's Your Perspective tomorrow also. You have to ensure that it is a portable, lightweight machine that you can carry around. It must have a high resolution imaging. That is, what you see must be pretty good. It must have something called a coplanar imaging. We'll talk about that later, which actually enhances the quality of your image. You must have at least one linear high-frequency transducer with which you can do almost all your blocks. It must have a color Doppler technology, and you must be able to archive your images. That is, you must be able to store your images and view them at a later stage. It actually gives you a lot of pleasure when you compare your first block with your 50th block. And you see that for your first block, you took almost 20 minutes, and for your 50th block, you just took 3 or 4 minutes. It gives you tremendous pleasure. And you can also transmit these images at meetings such as this and share them with your colleagues also. Let us look at some funny scenarios. Let us say during surgery, you were given the option of choosing between monitoring pulse volume and rate and blood pressure. Your surgeon was given a choice of opting between a ceiling-mounted light versus a headlight. Or you were given a choice of using surgical prep solution versus surgical drapes. You would say that the options that you were given were ridiculous, because all of these here are not competitive. They are complementary with each other. You will need to monitor both pulse and blood pressure to track your patient's safety during the intra-op period. Your surgeon will need all sorts of lights he can get to illuminate the surgical field, and you will need to use both prep solution and drapes in order to prevent infection during the surgery. So when you apply the same analogy to nerve stimulation versus ultrasound, there's no such thing as nerve stimulation versus ultrasound. Just because ultrasound is here today does not mean that nerve stimulators are obsolete. There are instances where you should be able to combine both. Especially when you're on the learning curve with ultrasound, it makes sense to use a nerve stimulator also. A lot of times you can't tell between a tendon and a nerve. If you use an ultrasound also and you get a muscle twitch, you know it's a nerve, it's not a tendon. The second thing is that for deep blocks, you always have to use nerve stimulator. There is no recommendation yet which states that for a lumbar plexus block, you don't have to use a nerve stimulator at all. So at least initially, when you're on the upswing of your usage with ultrasound, please try and use both ultrasound and nerve stimulation. So just the same way that you would buckle your seat belt and do make sure that it is on before you release your handbrake, I'd request all of you to also have a peripheral nerve stimulator attached to your needle before you perform your regional blocks. But no matter which guidance technique you use, this is what your end result should be. You must have an excellent block. Your patient and your surgeon must be happy with what you have done. Thank you very much.